Hi, my name's Kara. I'm a nurse and I work for the Mental Health Association. And today I'm going to demonstrate how to administer a water bolus and check a residual on a G tube, as well as setting up a new tube feed. So first, let me just show you all the supplies that we're going to need to do this. We're going to have our feeding pump. Every pump's a little bit different, but have pretty much similar features. It really depends on the manufacturer as to how everything's set up. But today we're going to use our cardboard example. We're also going to need a 60 ml syringe with a plunger, and that we're going to need for our water bolus and residual check. We're also going to have a graduate. The graduate has measurements on it, and that way you can measure out the appropriate ordered amount of water bolus. And we have our tube feed bag. It could be a bag. Sometimes they come as a container. Sometimes they come as a can where you need to pour it into this bag. That bag pops open like so, and it closes. If it's prepackaged, you're not going to be able to open it like that. It's already going to be sealed. The tube feed tubing with the piece that goes into the port of the G tube. Then this is our G tube. Some G tubes are only just one port with the balloon port. This particular one has two ports. We're going to use the middle port for residual check and water administration today. This balloon port we never touch, and I'm going to show you why. Again, this is the stomach. This is inside the stomach, and you'll see that balloon in there. That holds the tube from coming out of the stomach. And then you have this bumper on the outside, and it keeps the tube from going into the stomach. So this port is used when the G tube is actually inserted into someone's stomach. And how they do it, they use a syringe of basically it's salt water, normal saline, and you'll see the balloon. There's no balloon. Well, there's a balloon, but it's not inflated. So this is inserted into the stomach, and you can see if that balloon's not blown up or inflated, it's much easier for the G tube to become dislodged from the stomach. So again, we're not going to touch that. Only the doctor will be blowing that balloon up. So we're not going to touch that balloon port. The only port we're going to touch is the one that we use for the tube feed, residual checks, and water bolus administration. Okay. So we're going to put our stomach back together here. And we'll start with how we hang a new tube feed. Again, the bag or container, it's going to depend on the brand and who we're getting it from. But for the sake of this demonstration, we're going to use this bag. Now, every time you change a new bag, you're going to check the integrity of it, make sure there's no holes or leaks, and make sure it looks okay to you. You're going to time, date, and initial. So you always want to put the time that you're hanging the bag, the date, and your initials. Okay? Making sure that you're indicating for the time, AM or PM. The reason we do this is that a tube feed shouldn't be hanging any longer than 24 hours. Now, typically, the feed's going to run at a rate where it's going to run out before the 24 hours, but you never know. The person might have an appointment, or they might be out in the community where we're able to turn off the tube feed for a few hours, and maybe then we exceed the 24 hours. So it's very important that we time and date and always document when we've hung a new bag. This bag or container is always going to be hung above the level of the feeding pump. Okay? So we're going to say, for example, that's hanging up there. We have the tubing, which most likely will have a clamp. It will be clamped. What we're going to do, and again, each pump differs. Usually it's like a cartridge that you might pop into the pump, or it could be tubing that you kind of feed through. Either way, we will go through that as needed. We have our tube feed hanging up. We've fed the tubing through. Now we're going to click the pump. We're going to listen for that click so we know it's closed properly. And now what we need to do is it's called priming the tubing. We want to prime the tubing so that there's tube feed running all the way through the tubing to the end of this tip. We do that because you never want to push excess air into someone's stomach, because air equals gas, and that makes it very uncomfortable for that person. So the less air we put in there, the better for that person. So how we prime, there's actually a button on here that does the priming for you. You hit prime. Some machines will do it to, it will go to the standard of the tubing length. Some you have to actually hold the button. Some will go to, say, about here. You want to prime it until a couple drops come out of the top, so you know there's no air left in there. So say it stops here, most likely you're going to hold that button down until some comes out of the top. Okay, then you stop. Then what we're going to do is we're going to make sure that that G-tube is clamped before we open the port. Then we're going to open up the top of the port here. We're going to insert the tubing. Okay, make sure that's in there nice and tight, because they have a tendency to pop out. So we'll make sure that's in there nice and tight. If it does have two ports like this, we want to make sure that other port is closed pretty good. If that's open and tube feed starts going through that port, it's going to come out this way. So we want to make sure all the ports are closed, except for the one where the feed is going into. Okay, so now we can unclamp and unclamp on the tubing, unclamp the G-tube. All right, we're all set to go. Now, the doctor's going to order the rate that the person's tube feed should be running at. So, for example, we'll say that this person runs at 50 mLs an hour. That means 50 mLs of the tube feed solution is going into that person's stomach every hour. Okay? So what we'll do is we're going to press the rate button and we're going to punch in there 50 mLs. Okay. We've double checked the order, 50 mLs. We have 50 mLs. Some you can put the amount of volume that you want allowed to run in. Maybe they're ordered, 500 mLs every twice a day, for example. Okay, so you could put in the total volume that you want to be infused. So, for the sake of this demonstration, we'll say that we're going to put in, the bags and containers are 1,000 mLs typically. So we'll say we'll do 975, just for an example. So we'll hit volume, we'll put in the 975, we're good to go. We got the rate where we want it, the 50 mLs an hour, and now we're ready to start the tube feed. All right, we're going to hit run. We're going to make sure everything's running, everything's unclamped, the tubing's unclamped, the G-tube's unclamped, everything seems to be running smoothly. The pump might beep. It might be indicating that there's a blockage. You always want to check to make sure that everything's unclamped. You want to check the G-tube, make sure, everything looks okay. It hasn't become dislodged. It's not, the person's not laying on it. It's not like crimped up. That can block the flow as well. So after we've checked all those things, we can hit restart. Again, it depends on the machine, so I'm not going to get too specific about that. All right, the tube feed is running. It's been 4 hours. The doctor has ordered that we check a residual every 4 hours. And a water bolus every 4 hours. The doctor, again, we have to go by the doctor's orders. The residual check is every 4 hours per the doctor. The water bolus is every 4 hours per the doctor. And the amount of the water bolus. And we're going to say today that it's 150 mLs that the doctor has ordered to be given every 4 hours. Now, the G-tube, we're getting the continuous feed Or it could be intermittent, like I said, 500 mLs twice a day. But we're doing a continuous feed today. So the continuous feed requires typically that the doctor will ask that a residual be checked. A residual is the amount of stomach contents left in that person's stomach after the tube feed has been running for a certain amount of time. So again, it's every 4 hours we want to check per the doctor's orders. So what we're going to do is we are going to hit pause on our feeding pump. Okay, we're going to clamp all the tubing. We're going to clamp the G-tube. Then we're going to remove the feeding from the G-tube. And we can either put that cap back on that we had taken off when we were priming, or we're going to hang it in a place where it's not in contact with the floor or any other objects. The stomach isn't, we're not putting sterile contents into the stomach, but we want to keep it clean. Meaning, we want to try to not introduce any germs that we don't have to into the stomach. So we keep it off the floor, we keep it off of other things as well. Okay, we have this clamped. Now, to check your residual, you want to insert the syringe with the plunger already in the syringe all the way. We're going to insert that right into that port there where we inserted the tube feed. Now, we're going to unclamp the tubing. We're going to gently pull back on the syringe until we get no more contents, stomach contents out. Now, we'll say that this person has 40 mLs of residual. Okay? What we do is we push that 40 mLs gently back in. You always want to put the contents back into a person's stomach. Never discard it. Now, say the person, say we pulled out 60 mL and it's still going. Okay, clamp, we're going to pull this out. We're always going to have an empty graduate next to us so that we can empty the contents into that graduate. And then we're going to go back. We're going to unclamp and we're going to keep pulling until we don't get any more stomach contents out. Now, once we have gotten all of the contents out, like I said, we're going to say that we had 40 mLs of residual, okay? We're going to make sure that we keep that number in mind or document it at the time because that's something that we need to keep track of. So we had a 40 mL residual. Say we had 120 mL residual. The doctor will tell you how much they want to be in that stomach, or how 120, that's a lot of stomach contents, okay? So anything, typically the doctor will order, if, say the feeding rate is 50 mLs an hour, typically twice the rate, anything exceeding that, so for example, anything above 100 mLs as a residual, the doctor will probably order that you hold that tube feed, typically for about an hour, go back, check the residual, make sure that that residual is underneath those parameters, so it would be less than 100. And then you can restart the tube feed as ordered. But the doctors will order that volume, that residual, that frequency, and the timer interval for it to be held. Okay? So we always want to be checking that. So our person has a 40 mL residual. It's well below the threshold of the 100 mLs. So we're good to go. We're going to administer that water bolus and we're going to be able to continue that tube feed. All right. Now, we'll push the stomach contents back in very gently. If we're pushing it in and we have a little bit of air there, that's okay. We don't want to push that air in. Okay? Again, air equals gas. Very uncomfortable. So we'll clamp. We'll pull that syringe out, and then we're ready to administer our water bolus. So, one of the reasons we don't want to discard of any stomach contents is that it can throw off the balance of the person's body. Our stomach contains acids and bicarb, things that control the pH levels of our body. And if we get rid of those, it can throw everything off. So we want to make sure all those contents go back in. Even when you put it in that graduate and say you had the 120 mLs, you still want to put that back into that person's stomach. So now we're ready to administer our water bolus. When we administer a bolus, what we're going to do is, instead of inserting the syringe with the plunger in, we're going to take the plunger out. Okay? So we're clamped here. We're going to insert the syringe without the plunger. Now, one of the things I'm going to tell you is don't ever put your face over a syringe, over a G-tube. Okay? If the person coughs or sneezes or burps, the stomach contents are going to come flying right back up at you. All right? So, the other thing to note is that you just, kind of want to point it slightly away from you, and you always want to keep it upright, okay? Because if you let this fall down like that, the stomach contents or water or meds, whatever's in that person's stomach is going to come back out via gravity. So we want to make sure we keep that upright, okay? Now, the doctor has ordered a 150 ml water bolus. We're just going to pour about 10 to 20 mLs in first. We're going to have unclamped that G-tube. We're holding it slightly away from us, but up. We're going to pour about 10 to 20 mLs of water in there just to make sure it's flowing okay. And the water went down perfectly. That's great. All right. So now we're going to administer the rest of the water bolus. Sometimes the flow might be a little slow. If that's the case, you don't want to go above, you don't want to pour more water in than the 30 or 40 mLs. Again, going back to if that person coughs, sneezes, burps, any sort of intra-abdominal pressure is going to force the stomach contents out of the G-tube and up through the syringe. And we want to keep all of that in their stomach. So, about 30-40 mLs, and then just let it flow. We're going to allow gravity flow. Sometimes it might be a little slow. It might need a little push. All right, so in that case, what we'll do is we'll just gently insert the plunger and just a nice, slow, gentle push. Okay, again, not pushing any excess air into the stomach. We're going to clamp, we're going to pull that out, and then we're going to finish administering the rest of that bolus. Empty syringe, unclamp, placing, pouring the rest of that water in. And look at that, we gave it a little push, now it's flowing in nicely. All right, we got that water bolus in. We're going to clamp, we're going to remove the syringe, and now we're ready to reinsert our tube feed. We're going to pop that right into the port, again nice and tight, making sure it's secure. We're going to unclamp our G-tube. We're going to unclamp our tube feed tubing. We're going to hit run. We're going to make sure it's still set to the right mLs per hour. So 50 mLs per hour, it looks right. Everything's flowing. Everything's unclamped. The tubing's unclamped. The G-tube's unclamped. All right, now we can leave our materials here to air dry. One of the things we want to look for every time we're accessing the G-tube is we want to make sure that around the G-tube site where it inserts into the stomach, that it's not too red. You don't see any sort of excess drainage. There may be a little bit of drainage, especially with a new G-tube, but it shouldn't be like green or yellow or have any sort of yucky smell to it. So, if you do notice any of those things, you want to make sure that you let the healthcare provider and nursing know about that, and also be documenting. One of the things that the doctor might order is to put around the site, especially when it's a newer G-tube, is it's a type of gauze, and it's called a drain sponge. And what you do, the drain sponge has a little cutout here specifically for something, say, like a G-tube. So what you do is you remove the old drain sponge and you can place the new one right around the G-tube. And I'm just gonna remove this so that you can see how that's placed. Place it gently underneath the bumper. And don't worry, you're not going to pull the G-tube out unless you're really yanking on it. Again, it has that balloon inside. Be gentle though, because the area might be a little sore for the person. And you're going to place that there. Anytime you notice any excess drainage, the drainage sponge is saturated, meaning it's like really soaking wet. You want to remove that because it can hurt the skin around it. Anytime moisture is against skin, it can cause skin breakdown. So we want to remove that. The other thing that we can do too is put some Vaseline underneath the bumper, and that helps to protect the skin as well, without the moisture sitting on the skin. So either way, it's just meant to protect the skin and catch any excess drainage. So that is a drain sponge. A couple things to note with G-tube and feedings and water boluses is that a person needs to be upright at about 30 degrees or more. 45 degrees is better, but 30 degrees at least. And that's all the time. If somebody's receiving a continuous tube feed, all the time they have to be at least 30 degrees. They should never be laying flat unless they need to be changed and they need to be able to be mobile in the bed, meaning they're rolling side to side. In that case, we're going to put the tube feed on pause, on hold. We're going to disconnect the tube feed from the person, clamp the G-tube, and allow the person to roll side to side, or if they need assistance with that, of course, we would help them do that. As soon as they're done with being changed, then we would put them back up at that at least 30 degrees, hook them back up to the G-tube as I just showed you, and start the tube feed to run again. The reason that we need the person to be up at that height is because tube feeding can come back up, especially if there's a higher residual in there, but the tube feed can come back up the esophagus, and it can lead to aspiration. What aspiration is when food, liquids, even saliva, if it goes into the lungs, that's called aspiration. And that can lead to some pretty serious complications, mostly pneumonia. So we try to prevent that at all costs. Some signs of aspiration, things you always want to be looking for, is if the person starts to have any difficulty breathing, especially after administering a bolus, because you're adding all that excess fluid into that person's stomach. But at any time, if they have difficulty breathing, we want to stop that tube feed immediately. Other signs of aspiration might be coughing. Of course, a person with a G-tube may not have that reflex to cough, so that's not always a reliable sign. Other signs might be that they appear hypoxic. Again, difficulty breathing. Their O2 sats are dropping. Their increased confusion is a sign of hypoxia. Sometimes if somebody's lying flat especially, you can actually see the tube feed come back up. You might see it come from their nose or their mouth. You definitely want to stop the tube feed at that point. It shouldn't be running when they're laying flat anyways, but that's typically when you would see that. Those are all signs of aspiration, and the tube feed should be stopped immediately upon any suspicion of aspiration. The provider should be contacted and nursing should be notified. Other than that, I think that's it for our lesson for today, and I thank you for joining me.